This happened like a month ago. Put like this weird like AI porn.
All right, so we're streaming here. I'll just pop over to Facebook to confirm, and then we'll get going. There we go. All right. Got people joining the room quickly, and I love to see that. Let's not keep them waiting. Hello, everyone. Welcome back to Luncheon with the Experts at Carcinoid Cancer Foundation and LACNet's program. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and a writer, among a few other things, that's been working with CCF for over a decade now. We are getting into, I want to say, year 13, maybe even 14. I try to stop the time. It doesn't work. And in that span of time, a decade plus, we've created, I've lost count of how many videos, live video series like the one you'll watch today, patient-centric documentaries, treatment-based videos, but all with one mission in mind, and that is to spread awareness and education about NETs. Now, if you are new to the show, I want to say welcome. I encourage you to introduce yourself. You'll see people doing that in the comments. Tell us where you're signing on from. Hello from Kansas. Hello, Nancy from North Carolina. I'm also in a snowy North Carolina right now. Introduce yourself. If you're new to this community, whether on the show or the overall NET community, one of the things that impresses me every single day of working alongside this community is the strength and support of it. So embrace that community. It will embrace you back. So meet people, talk to them, et cetera, et cetera. Okay, for today's show, we have a very special show. Welcoming back to the show, it's been a while, Dr. Eric Liu with Heather Mauceri. Heather and Dr. Liu, how are we both?
Great. Thanks for having us, Rain.
Absolutely. So I love this dynamic duo, this team. For those that may not be familiar to what you do and how you work together, give us a little bit of information about where you work, your team, and the role that you both fill in this NET community I alluded to.
Hi. Well, most of everybody knows me as Nurse Heather. I work with Dr. Liu at Rocky Mountain Cancer Center here in Denver. You may have seen me on a Facebook Live with Dr. Liu or met me in the office, but Dr. Liu and I work at our comprehensive neuroendocrine center here. We see patients, we have imaging capabilities, we are able to do Lutathera and other treatments all here at our facility in Denver.
Got it. Well, appreciate you being here. Folks at home, just a few guiding principles, best practices, if you will, to help you get your questions answered. There's no limit to how many questions you can ask. We can't, in this format, very well handle very case-specific questions. So the best way to get your answers, or your questions answered rather, is short, generic chunks. Now, if we need more clarification, we'll come back to you. Again, I'll reiterate: there's no maximum to questions that you can ask. We will probably get a lot today. But if you ask them in short chunks, we will be able to get to them a lot easier. So go ahead and start sending in those questions. By the way, how is everything in Colorado these days? Is it snowy there? I'm looking at about 4 inches uncharacteristically in North Carolina right now.
It is very cold here. It is very cold. We are probably both wearing tall socks that may or may not have zebra stripes on them.
Yes. Oh, by the way, I think I'm a little out of focus, but my zebra is right back there, but not as much as you all have in this office. Okay, listen. We got questions rolling in already, so enough of the chit-chat about the snow in North Carolina. Let's go ahead and start taking some of these questions. And as we suspected, Histotripsy is coming in hot. The question is from Merlin, how is your Histotripsy program going?
Hold on a second.
Yes.
Live demonstration. For a very, very, very long time. Hey, Merlin, look what I got here, pal. Look at this. Look at this. This is from Merlin.
Nice. See, there's the strength of the NET community right there.
Yeah, let me show you. Let me show you what else I have in this office. Merlin doesn't come visit me anymore because he has a better doctor out there.
Ooh. Yeah. Shots fired, Merlin.
Yeah. Look at this, pal. I think about you every day because I have to look at this every day.
So our Histotripsy program is, it's smaller than some of the other centers that are doing it. We probably have done just under 50 histo cases. We have, we do histo for not only the neuroendocrine, but if other patients have other types of cancers with mets to the liver, we are also using it on those patients. Have we seen the great success that everybody was really hoping for? No, but we're still learning and trying, and Dr. Liu is working closely with Histosonics to kind of perfect the techniques, revise the protocols. We're doing some more testing with it. So, there is still hope. It is new.
Yeah, let me add on to that a little bit, Rain, just so people understand. So we've done a lot of them, and some of the other colleagues have done a couple of them, and our friends down in New Orleans have done a few too, but no one has pushed it as hard as I have. No one has pushed it as hard as I have. And what I found is there's something different about neuroendocrine. It's like the texture of the tumor. There's something about the biology in which it doesn't quite kill as well as it does kill for like a liver cancer or a colon cancer in the liver. So we're still working on it. So we've actually taken a tiny little bit of a pause from doing neuroendocrine until I can figure all this stuff out. The company, they're wonderful people. Let me just make sure you all know this. They're wonderful people. And you know what? They already cashed my check for the machine. So, I got it. But it's not as magical as I hoped it would be. It doesn't mean that there aren't still other techniques, liver-directed therapy or ablation, laparoscopy, surgery, whatever. We still have lots and lots of tools in the toolbox. This one is just not exactly completely worked out. It doesn't work exactly as well as I hoped it would. And we have more work to do on it. So I would say just hang tight, be patient. This is an example of sometimes the hype may not exactly match what it is. It's better for other kinds of cancers. That's the whole thing. Yeah. And when they did their first clinical trial, they did it with, I think, maybe like one neuroendocrine patient. So we didn't have enough information. Now that I've done this like 30 or 40 times, or whatever, how many times we've done it, we've learned these things, and I have really pushed it and I've really tested it. So all I would say is everyone should just be cautious. I'm cautiously optimistic, and that's kind of how we are now.
That's totally fair, and I think it's a good approach. Obviously, I know that when something new comes out, it's hard not to get excited. So I appreciate you including that. Moving on, next question from Olga. For how long do you have to isolate after PRRT?
So different programs and different centers will have their own specific guidelines. There are an overarching, radiology, can't think of the name, nuclear medicine guidelines. Typically, we have you isolate for the 3 full days here with us. Different centers have different protocols. It is also, it's time and distance, kind of basic radiation safety.
Got it. Thank you. Thanks, Olga, for your question. Next question from Sarah. What are your thoughts on stereotactic radiation for bone mets or for cardiophrenic lymph node?
Well, I can answer that question. So just to back up a little so everyone understands,
Thank you.
Neuroendocrine tumors can actually spread to multiple different places. The most common place are the lymph nodes and the liver, but it certainly can go to the bone. So it depends on what you're trying to accomplish. So in general, stereotactic radiation is where they shine radiation in, right? It's not like injectable radiation like liver-directed therapy or PRRT. They shine it in. And then here's what I think about it specifically for bone. I don't treat bone tumors unless someone is hurting, if it causes them pain. In general, I find that the XRT, so external beam radiation therapy, XRT, is less effective and doesn't last as long. That's the problem. And so what Heather and I like to do is we like to work with our interventional radiology colleagues And we like to actually destroy the tumor and then kill it and fill it with cement so that the bone is stronger. It works better. It's more effective. It's not, I mean, nothing's perfect, but I think it's better personally. But again, this is the kind of thing where you have to think about it and use the right tool for the toolbox. I'm not saying XRT isn't a wonderful tool. It's just that I don't think it's quite as effective depending on what the tumor looks like.
Got it. Thanks, Sarah. Next question from Samantha. Miliary growth of liver tumors. What can you explain what it is and how it might impact treatment options?
Sure, let me answer that one. So if I understand her question, what miliary means, the word miliary just means like tiny little ones, lots and lots of tiny little ones. So in general, neuroendocrine tumors grow in a different patterns in the liver. They either don't grow in the liver, which is awesome, but not that common, but it does happen. Or they have like a few small tumors. I think I saw something scroll by describing that. And then sometimes they have a few and they grow differently. Like some are big and some are small. And then in a less common, it does happen, but a less common situation, it just goes bang. And it's like a starry night. So in general, surgery is not a great option for the ones that are all over the place because I just can't pick every single out. It's like you trying to get every single ant out of your yard. It's just not possible and doable and practical and beneficial, really. So then usually what we do is we rely on liver-directed therapy. So liver-directed therapy is when the intervention radiologist, so we have a dear friend named Dr. Charlie Nutting, dear friend, wonderful, incredible expertise. I think you've met Dr. Nutting, probably, right?
Absolutely, he's been on the show, yeah.
Yeah, and he, we've worked with him he's treated so many neuroendocrine patients, and his expertise and his skill makes a difference. And really, it's about the judgment, if you ask me. And so what he can do is he can either treat some of them locally with either some of his little beads to cut down the blood supply. Some of it maybe he shoots a little radiation to it, and sometimes he can even treat the whole liver. So all these things require judgment. So miliary, maybe it's if the patient's totally stable, you can hang tight, or you can treat them with systemic therapy such as PRRT because they have other stuff anyway, or you can treat them with multiple repeated episodes of bland embolization, almost no sweat off your back for that. And then if necessary, the judgment is correct, then even the whole liver radiation is a reasonable option. But again, the devil is in the details. I mean, truly, it is the devil's in the details. If you look at this office, there is a reason why there are a bunch of zebras everywhere you look, right? Because, and I didn't buy any of these things. These are all wonderful, thoughtful gifts that mean a lot to me and to the patients who give it to us. But the zebra thing is real because everyone is different. Every single zebra is different, and every one of you is different, and every one of the tumors, even in your body, is different. And so when Heather and I work to take care of you, we think at a very, very granular, detailed level because that's what it is. And so when people ask us all the time, hey, can you just tell us what to do? I'm like, no, I can't tell you what to do. We have to figure it out. She and I have to study your case, and we got to figure it out. But look, if you come to our office, you will see all the zebras, all the things, on the feet, on the wall, on my tie. Yeah, for sure.
Bracelets.
On the bracelets, yeah.
Y'all are awesome. Next question from Reese. I understand PRRT is slow acting, but I'm on my third line of chemo. Do you ever do PRRT with chemo?
Well, that's hard to say because the problem is they have you can explain as well.
Yeah, no, I mean, the devil again is in the details, making sure, that you're strong enough for PRRT, because sometimes the chemo really brings you down. And with PRRT, we really have to watch your blood counts, platelet levels, your kidney functions, all of that. So sometimes with chemo, you have a negative effect on your blood work. So we need to optimize you. So sometimes. And
they can overlap too. Yeah. That's the problem. They're overlapping side effects. So you got to be real thoughtful and real careful about that.
Yeah. So yes, doable, but details.
Gotcha. Thanks, Reese. Let me know if you have another question from Julie. Going back to histotripsy, are there tumor size limitations with histotripsy?
So each physician that uses histotripsy has a different comfort level with the machine and a different, how aggressive they can be. you as a patient, also your body is going to determine how aggressive we can be, what your response is. So we'll pick a target lesion, but there's not a specific measurement per se. There's only the treatment zone is
3 centimeters by 3 centimeters by 3 centimeters. It's a sphere.
Yeah.
Got it.
But then you can like overlap the spheres, right? So what happens is if you get away with one, then you can take another one and you can put them side by side to try to get a bigger range if you have a bigger tumor.
Mm-hmm.
Or the other thing too is if the tumor is small, right? Let's say the tumor is like this and you want to get it within that zone, then you can cover it. But those are all very, very technical things. You have to just, it's a tool, right? You got to just figure out what is the right tool and what is the right treatment and what you can and can't accomplish.
I'm sorry, do you have a full-on pool table on the other side of that camera?
Where's the magic 8 ball? Right. And the magic 8 ball.
I see that.
Because tumors come in different sizes, right?
Oh my God. From Melissa, with functional gastronoma, no known primary, but multiple lymph mets, some bone and some liver mets, would you advocate for any surgery following PRRT?
Well, it depends, right? That's the problem. The answer is yes, maybe, right? So there's always a primary. They just didn't find it. So if the patient's doing okay and you want to just kind of sit on the PRT for a while, that's perfectly reasonable. Mm-hmm. If they're very symptomatic and there are larger tumors that can be debulked and kind of just get it cleaned out a little bit to get it, to get it to a lower burden of disease, that's very acceptable too. If the patient's very, very sick and has just ulcers and constant diarrhea and is sick all the time, then you should embolize it first and get it under control. So you see, it's complicated because you need to think about which tumors, what tools can affect those tumors to help that patient feel better.
Yeah. Thanks, Melissa. Carcinoid syndrome question from Rudy. When I was diagnosed with NETs 4 years ago, I appeared to have carcinoid syndrome because of flushing diarrhea, elevated 5-HIAA. However, since taking lanreotide once a month, the flushing diarrhea are not as apparent. My oncologist is stating that I probably don't have carcinoid syndrome and consequently don't have carcinoid tumors and is reluctant to approve proactive annual echocardiogram transthoracic test. The question is, could the lanreotide be masking the carcinoid syndrome symptoms? And is there even a definitive test for carcinoid syndrome or carcinoid tumors rather? Pardon me.
Yeah. All right. So do you want to answer that? Because it'll just drive me insane.
I know.
All right. I can repeat too. I know that was
No. It's not that.
Okay.
It's not that. It's what the doctor said.
Fair.
Yeah. So with carcinoid syndrome, heart syndrome, if when we see patients and they have an elevated serotonin, that is when we proactively will usually get that patient on an echo surveillance schedule, like doing one echo to check their heart valves to see. How else would you?
Let me explain. Okay, I think I understand what this patient is asking. I'm not exactly sure, but here's the deal. So this is a little bit more difficult because this patient apparently does not have cancer or tumors from the way that you read it to me, Rain, because they said they couldn't find it or they weren't doing proactive things. So what can happen, just so everyone understands, is that there is a very, very clear classical what we call carcinoid syndrome, right? So carcinoid is a little bit of an old, antiquated term, but we still use it a fair amount, right, for carcinoid heart disease and stuff like that. Mm-hmm. The problem is you can have symptoms without having cancer. And people are like, well, how can that possibly be? Well, I say people all the time. People have overactive thyroids all the time. People have underactive thyroids all the time, and not everyone has thyroid cancer. And so it's the same is true for neuroendocrine. Yes, it is true that most of the time people have some sort of malignancy, unfortunately, right? But in general, they're relatively straightforward and easy to find by the time they're quite symptomatic. So then what happens is now you've got people who are symptomatic and have no cancer, right? I've done this before. Yeah. You look, and nothing shows up for years and years and years. In fact, there are people on this thread who are like this. And then it becomes, okay, well, the good thing is I can just cross off the fact that you don't have cancer. It's about to kill you, right? Eat your liver, destroy your bones, give you a bowel obstruction and kill you. But there's something going that's torturing you. And then the analogy I use is like, okay, clearly the timing belt of your endocrine system just isn't working. Well, then I'm still very, very, I'm still a champion of quality of life. So if you don't feel good, well, then we should find some way to make you feel better. If you're flush, so here's the deal, Rain, with the shots. The shots are almost magical in some cases, but what happens is it's a suppressive hormone. That's what it does naturally. That's what it does in all of us. Right? I mean, I don't think I have neuroendocrine, but the natural somatostatin that I make in my body helps to regulate and control my endocrine system. So when you use a synthetic form of it, then all you're doing is suppressing the natural endocrine system that normally has. And if theirs isn't working, and the shot is helping, that's awesome. That's really great. But then it becomes, if you don't have like a malignant source of the hormone, the risk of having carcinoid heart disease is almost zero. The only reason I don't say it's zero is because you never know, right?
Sure.
But it's essentially zero, because there's no malignancy to drive it. And if someone's serotonin levels are normal and their urinary 5-HI levels are normal, then that's not the problem. The problem is that they're symptomatic. And then you've got to find some way to make them feel better. And clearly, in this case, the shot is what helped them. So you don't have to go crazy hunting it, but you got to make sure you do your homework first, right? So a lot of people on this thread know that I'm a measure twice, cut once kind of person. And so I hunt and I hunt and I hunt and I look and I make sure. And once we're all convinced that there isn't something horrible happening, then you can take a deep breath and then work on the symptoms and go from there. So that was a very long-winded answer to a very focused but unrecognized and underappreciated issue.
Appreciate that. And thanks for your question. Next question from AG. AG says, update on the appropriate use of the Signatura blood draw for NETs?
Oh.
Well, so
figuring it out.
Yeah, so we're still figuring it out. But there's no, okay, let me explain. Let me back up a little bit. So Anne's question is basically, there's a new test. It's not so new, but there's a test that takes a little bit of your tumor, grinds. Well, you can tell them.
Yeah. So when we take your tumor out, we will send a piece of it to Signatera, and they
Natera, the company's called
Natera, and Natera will essentially spin it down and figure out its call sign. What's its name, and then they're going to
signature. That's why it's called Signatera. It's like a signature.
They will then look for that signature in your blood and in your blood draws. So your first blood draw, you might have just had the surgery to remove your tumor. You may be, not quite at zero yet. And over time, you may get yourself down to zero and stay that way. And then maybe 3 months, one of your tests, because they're done every 3 months typically, may show a positive, a 0.1, 0.3, 0.03 positive. And that gives us a clue to maybe see how you're doing. And maybe if it's a big jump, to look at your scan schedule and maybe move things up. So every time we get your results back, we look at the positive ones. And if it's a big jump, we talk to the patient, kind of see how they are and figure out, are we going to wait the next 3 months and see what happens? Because sometimes they go up and down. It's really hard to correlate how big of a jump means something. So we're still figuring it out.
Here's the problem. Heather and I are busy, and there are like 3,000 data.
And that's not even all of them, because I stopped putting them in the book.
Yeah, and so the answer to the question for Anne specifically is I cannot tell you for sure, because we haven't sat down and done the tight analysis. What I can tell, the official analysis and all the statistics and stuff like that. What I can tell you is I'm optimistic. That's all I can say.
Fair.
It works well in other cancers. Colon cancer is a great one that uses the Signatera tests, and it's very reliable for them.
I think they use it for breast and bladder and some
Mhm.
other things. Yeah. So we're working on it. We're just busy. That's all. Yeah.
From Gloria, if NETs have spread to lymph nodes, they'll light up on gallium-68 scans, right?
If they light up, they will light up on gallium. That's right. It doesn't. It's not about where it is. It's only about the biology of the tumor.
Had a couple questions with follow-up scans. Lynn says, what standard follow-up testing, labs, scans, etc., do you recommend for 10-year no evidence of disease?
So again, devil's in the detail. It really depends if, have you had a PET scan? When was your last one of those? Do you have any disease in the liver? Where was your primary? So it's in the details, and everybody has an individual surveillance plan based on their disease, their zebra.
Got it. From our friend Pat. Hey, Pat, what are the current options for a lung net who now has DIPNECH?
That one's a you.
So, there are lots of options. In general, a patient who has DIPNECH, so let me back up a little bit. So DIPNECH stands for diffuse idiopathic pulmonary neuroendocrine hypertrophy, and there are a bunch of growths, and so they're tiny little growths inside. It's like moles in your skin or freckles on your skin, except they're the little neuroendocrine cells of your lungs. And sometimes one or two of them can get a little bit bigger and escape. So we treat it generally similarly to as we would treat any kind of bronchial neuroendocrine tumor, which is with the shots or with the pills or with the chemo or whatever it is. And then sometimes if one or two of them are just misbehaving, we may just chop it out. You can get a little wedge or just a tiny little lobe or whatever it is. But it depends on how fast it's growing, how much it involves. Is it symptomatic? Is it blocking some airway? Is it doing something bad? And if it's not, then you can just sit on it until it does. And then when the time comes, then you do it. Right? So I tell people all the time, it's not always what you do. I'm sorry, the art of neuroendocrine is not what to do. The art of neuroendocrine is when to do it. And that's where the judgment comes in.
Got it. Thank you. From Jeff, any new insight into a newer regimen for heavily pretreated G3 patient who has run the gamut of modalities? Any application of DLL3 here?
Well, there are a bunch of clinical trials. I'm hopeful. Actually, the one thing I will say that's really been powerful. So, Carcinoid Cancer Foundation, LAC-NETs, Healing Net Foundation. I think what we've done very successful in the past decade or two or three, however long CCF's been around, or 5, right? He's been around for a long time. I don't even know how old is Dr. Warner now. 95? I think he's 95.
Yeah, it's over 50 years. It's like 55 years since the foundation.
Exactly. So the one thing that's really helped, really helped, is the awareness. And so now even some of the companies are becoming interested in neuroendocrine and doing things and including in their trials, where in the past they were never included. They were almost essentially excluded. So yes, the answer is, I can't answer that question, right? Because I don't know what gambit means, right? I have no idea what gambit means. But what I can tell you is that the awareness of clinical trials and the potential use of new types of therapies is very encouraging. So DLL3 it's a molecule called delta ligand like 3, and it is a target possibly for lots of different kinds of cancers. But G3 is not all the same, right? So it depends on what G3 really means. And I'm not actually asserting the question. The only problem is there's not enough information for me to answer the question. What I can tell you is it's very encouraging. I think there's new stuff, new alpha PRRTs, new molecules, these adjunct kind of molecules, conjugate molecules that we have. So there's all kinds of neat stuff happening. And I'm just very thankful that they're starting to include neuroendocrine as part of their test group.
Got it. Thank you. Next question. From William, my first run-in with carcinoid tumor in 2001, removed by bronchoscopy, told by pulmonologist I was cured. Fast forward to 2020, new tumor found just below the original site, ended with bilobectomy or RML and RLL. Thoracic surgeon says we can stop scans next year. I disagree. Is that correct, and should I travel to see a NET specialist?
Well, you should always travel to see a NET specialist, right? Because clearly whatever you were told the first time was not true, right? Obviously.
Fair point.
So whoever you're seeing clearly doesn't have experience. And I will tell you, I remember when I was a kid and, training, and we would sit with these revered thoracic surgeons and they would say these things. And now I'm an old man now, and I just learned that what they said was wrong. What they said was just wrong. And admittedly, it was a different time. It's a different disease. These people, there were no essentially neuroendocrine specialists. I mean, goodness gracious, lungs especially. But what they said was wrong. And so what I have come to tell people all the time is that you need to find people who tell you these things. You need to find people who do this, who understand. There's a difference between where the lung tumors are located, how they respond, how they're imaged. Most of the time, the lung docs, and they're smart people. I mean, it's not bad. It's just they do lung cancer all day long, right? And lung cancer is not neuroendocrine, period. Pancreas cancer is not neuroendocrine, period. Bowel cancer is not neuroendocrine, period. But they treat it like it's their kinds of cancer. And that's the problem. And that's the trap that people fall into. So clearly, the advice they got initially was incorrect, right? Clearly, the patient wasn't cured. So, I mean, this is an obvious answer. Yeah, go find someone who knows what they're talking about.
In general, what's your thought of that word? I know a lot of NET specialists don't even like to use that word, cured.
Well, these people have heard me say it before, Rain. Cure is a little bit of a four-letter word for us, right? Because we've had recurrence. I have seen I have a patient who lives up here in Colorado. She was operated on by, I know the surgeon from like 40 years ago. And he told her that she was cured. And then just as it would be, we met, I live here in Colorado, and she came to see me, and I said, oh, okay. So we did a scan, and she has metastases all over her body. And I was just like, look, I get it. If you were to ask me all about brain cancer, right, I would not know what to tell you. I can give you some sense of it, but I cannot tell you. But the difference is I would tell you that I don't know what I'm talking about, right? Because I said this on Tuesday. If anyone was here a bunch of you were on with me on Tuesday. My ego should never get in the way of your well-being, period. If I don't know what to do, I will try to find someone. I mean, I will support you and do all the things we need to do and help you. I will follow orders. I will follow instructions. But thinking about it and calling the shots is difficult. And, I do that for neuroendocrine patients all the time, which is fine because I'm good at what I do. But when it comes to anything else, I am just, I'm the helper, and I'm happy to help you however I possibly can. But it would not be fair to me to say, oh, well, don't go see that doctor because, they don't know, because they're an expert in neuroendocrine. You're hurting my feelings. Yeah. Don't worry about hurting my feelings. No.
Yeah, so I never do.
Yeah, I don't question that, Rain. Nor does Lisa, to be totally honest. Yeah. So, but my point is that your well-being is and always should be the highest priority. And if their feelings are hurt because you're questioning them, then you need to find somebody else. Because you'll never hurt I've said this to many of these people on here. You'll never hurt my feelings if you're doing well. I will only be happy for you. And if I'm wrong, sweet, that would be awesome. Mm-hmm. And if you're doing great, awesome. Because you're doing well. And that's it. Period. That's all.
Well stated. Everyone in the audience is applauding right now. You just can't hear them. Perfectly stated. I love that. From Janet, what is the best post-Whipple for liver mets up to 3.1 centimeters?
So let me explain that. So when you have a Whipple procedure, that's what's called a pancreatic duodenectomy. It's for pancreatic neuroendocrine tumors. It removes the head of your pancreas and your duodenum. It's a very complicated operation. It's become much more safe now, but it's a problem. It's not a perfect operation. The problem is when you do it and then you develop liver metastases, it limits some of the things you can do. So you can do more surgery. You could possibly do what's called a radioligand. You can do radioembolization. That's what liver-directed therapy, radioembolization, What doesn't work so awesome is if you do a bland embolization, because the risk of developing an infection is very, very high. When you cut all those bile ducts, or the bile duct, all that bacteria flows into your liver. And then the moment you cut off the blood supply because of an embolization, it causes an infection. It's not 100%, but the risk is it's like over 50% of people develop some kind of bad liver infection. So you have to be very, very, very thoughtful about what it is you're trying to accomplish. So I don't love to do Whipples for tumors in the head of the pancreas because it just recurs and you have a problem. But that's just my experience and how I feel about it. But I've just seen it so many times. So yes, there are many options. There are things you can think about, things to do. It depends on where. 3 centimeters is a very moderately sized tumor. Whether you do today or tomorrow depends. Yeah.
Got it. Thank you. From Sasheen, talking carcinoid heart disease, after the initial valve replacements, do you ever see it return, or is it a one and done? I know controlling carcinoid syndrome is important in prevention, but what else is a factor in preventing recurrence?
First of all, Sasheen, instead of like watching my mug all day long, you should get some rest. I mean, come on. Oh my gosh.
She said hi again. I'm a fan.
Again from Tuesday, right? Anyway, so let me back up a little bit because she's been a wonderful advocate in sharing the knowledge of carcinoid heart disease. So what happens is whatever hormone is serotonin, I mean, I don't really know, but let's say it's serotonin. When it floods your valves, some people are very, very susceptible to their valves breaking down and it scars it. So normally when your blood flows like this, it flows in one direction, right? And then bang, it stops. But when you have carcinoid heart disease, it shrivels that valve. So then now your blood flows backwards. Okay, it flows forward and backward, forward and backward, forward and backward. And it's really, really not good for you. I mean, obviously. The problem is when you replace a valve, it can just wear out. It's usually a pig valve. And it wears out, and then you need a new one eventually. Now, the great thing about it is that the technology has improved so much so that when you have a new one replaced, you can just replace the leaflets. So in general, what I do is I always have the person have open heart surgery initially because you got to get the ring to fix, right? Because it's gotten so mushy that you can't do anything with it. So you fix a ring to it. It's almost like a frame. And then it has valves and it works for whatever, 5, 10, 15 years, or whatever it worked for. And then they can go in there and just replace the parts. So they can replace the leaflets as long as the ring is in place. I mean, they're very, very, the cardiologists are very good at this now. And so it's really quite an astonishing thing. So that's how I deal with it. And we've dealt with it and people are doing great. The problem is you must diagnose the problem quickly. Because when people don't just let it linger and linger and linger, people do terribly because their liver is sick, their kidneys are sick, their muscles are sick, their legs are swollen. They don't eat well because their bowels are sick because the blood is flowing backwards. I know this sounds ridiculous, but people let their patients' blood flow backwards for months and months and months. And if you don't figure it out quickly, you can't fix it. I've had multiple people walk in the door and I'm like, I look at them like, what is going on here? And she's like, I don't know. And then you figure it out. And you're like, well, you're having open heart surgery next week, period. There's no negotiating this. And they're all alive.
Mm-hmm. Yeah, they do really well. A lot of times, people don't always tell us all the symptoms. So when they're not feeling well, so, if all of a sudden you're having some shortness of breath when you're, walking from your car to the house or carrying groceries, or you've noticed some swelling, those are all things that you want to let your care team know so that we can start investigating it.
But that's for people who understand neuroendocrine.
Right.
The problem is if you tell other people, they won't even know. I mean, the problem is it can be caused by blockages in your venous system. It can be caused by carcinoid heart disease. And we have to figure these things out. And this is what the problem is because they get to us so late. And I get it. I mean, making the pilgrimage up to the mountains is not easy. I get it. But sometimes it's like, oh my gosh, we could have fixed this 6 months ago or 9 months ago. Yeah. And it can be a problem. And I'm just on my soapbox now, Rain. So just
ask another.
Yeah, question. Enjoy me from the soapbox. Yeah, but that's why I always ask and beg people to see a neuroendocrine specialist as soon as possible. Yeah, just to get a once over to figure things out. Because if you can do it when the patient's healthy, they will do better. Period. People have heard me say this before. If you can have surgery, if you can do all these things, do it when you're strong. Do it when you're healthy. and then you will recover better. When you do it when the poop has hit the fan and you're in the ditch, then it's much harder for me to save you. It's much harder. It's much more work, and the risks are much higher. And some people don't do well, and that's the challenge.
PRRT question from Emily. Emily says, I just finished PRRT in December, had a PET scan in January. Didn't show much improvement. Was the PET scan done too soon, perhaps? How long does PRRT continue to work?
So typically the scanning after PRRT is location based, what program you're with. We here at RMCC typically rescan with your PET scan 12 weeks after completion of your number 4 treatment. We do not scan in between cycles. So we wait till the end. So yes, possibly that scan could have been too early for you to see the full benefit. Because remember, PRRT does take a while and you want to see the full effect.
Got it. Follow-up question for that. She says also two tumors showed more active, but couldn't that mean they are possibly in the active dying process rather than just assuming they are growing? How do you know which it is? Does that make sense?
Yeah, so devil's in the details, and we really have to look at the images and really look and compare. So we have to look at the pictures to give you a good answer on that one.
Got you. Thanks, Emily. I hope that helped. Question, where did I see that one? There we go. From Vivian, at what point do you add Zermello to treatment? Rampant diarrhea and high 5-HIA only, or something else? It doesn't seem to be mentioned very often in net Facebook groups.
So we use Zermello if you're having symptoms, if some of your hormone levels are high, we definitely will try it.
By the way, water is a fantastic diuretic. Glad Heather was here to fill in for me.
Cheryl says, is the bone and joint pain associated with this cancer a result of the disease or a result of the treatments, octreotide, finished PRRT, etc.? My primary tumors in the small bowel, mets to liver, lymph nodes, and bones.
So a little of both. So yeah. So the lanreotide does have, or sandostatin does have some, some side effects of some of that bone pain, bone fatigue feeling. If there are tumors there. So all of the above was the answer.
Oh, I got to answer this one here. Ann says, have you heard of Dr. Lowell Anthony at the University of Kentucky? Is he a good neuroendocrine specialist? Ann, do me a favor. Go see Dr. Lowell Anthony and tell him that he's not as good as Dr. Lou. That's all I want you to do for me, sweetie. Do that for me. Yes,
he's good.
Very good.
That's another.
Please tell me, are any of the other doctors nearly as funny as we are?
Well,
answer honestly.
Listen. I love all net specialists and doctors. I've had my media training, sir. The thing about it is, no, bud, you take the cake. I will say though, it very much demonstrates the strength of the community that I mentioned earlier. All the doctors know each other. Everybody in this space tends to know each other and support each other, and I really love to see that.
That is true. But I'm the funniest, though.
You might be up there.
No,
be up there.
I'll keep working on it.
Yes, you got to refine your act. I was going to tell you, just the other day I saw like the first video we ever did together, which I was trying to confirm the date, but I think it was 2012, maybe 2011 in Ottawa, at a conference in Ottawa many years ago, my friend.
That was a long time ago. I remember when I first met you, Rain. Yeah, it's been a long time.
We're both getting older, pal.
Well, look at all this hair, pal. Look at all this hair.
Yeah, I will. And now my gray has to come here in the beard. From Lauren, have you had any reports rather of extreme rage and depression 3 to 5 days prior to lanreotide injections, and how do you address it? We're continuously being told it's not related, but 4 years later it's like clockwork. And I will also say on Lauren's behalf, I bet multiple people will chime in about this. I've seen this before on the show. Thoughts, team?
Well, I don't. Does my wife take lanreotide? Because that would explain a lot.
Oh my God! Don't get into trouble today.
Thanks, pal. Thanks. So the answer to the question is absolutely, for sure, no question. So whatever that doctor told you is not true. That is not true. Emotionally, it's serotonin, for goodness sake, right? I mean, look, there's a 10 bazillion drug industry targeted just towards this hormone. So to possibly think that you have metastatic disease and it doesn't affect you emotionally is just crazy. It's ludicrous. So it does affect you, period. And it may be the pain, it may be maybe other things are contributing to it, but the hormones are a huge part of it. So what I tell people all the time is if we can get better control over your disease, that's always the first thing to do. But the quality of life is extremely important. So we talk about flushing, we talk about diarrhea all the time, but one of those symptoms is emotional lability. So like kind of a brain fog, right? Go. All you people here, how many of you have brain fog? Right? I'll bet all of you will say that.
Type right? Fog in the comments.
That's right. Just say absolutely or whatever it is. So the answer to the question is yes. And so if you feel like it's symptomatic, you feel like it's causing you problems, then you should tell your physician and work on it and maybe adjust what it is or add some short-acting treatment, whatever it is that can help with the symptoms, you should do.
Got it. Thank you. From Julie, I have about 7 tumors in my liver now after surgery 5 or 6 years ago, several in my abdomen and lymph nodes. I've gained quite a bit of weight. The doctor put me on Ozempic because of weight and diabetes. It made me very sick. What are your thoughts about carcinoid patients going on this method of treatment for obesity and diabetes? I have heard this before.
Well, I think I know Julie. So yeah. So here's the deal. So Julie, at some point, if you want us to talk again, you should. Since I do know you, we should talk again. So because I haven't talked to you in 6 years. It's been a long time since I've talked.
I think you're right. That's what she says.
6 or 7 years, yeah. So the answer to the question is we should probably talk. But we definitely have people who have gained weight for various reasons, and most of the time it's actually helpful because they've lost so much weight that you want to get them stronger and build up. I cannot give you any hard data or anything about Ozempic or any of these new weight loss drug, whatever drugs, because I don't know enough. What I can tell you is I've not sensed, my spidey senses have not seen anything obvious. Mm-hmm. So people take it, they seem to be doing okay. They lose their weight, it does all the things, and it does not. I have not seen a huge, massive spike in their tumors, and I was looking for it. And I didn't see it. So as far as I can tell, there's nothing that's alarming me.
Yeah. But no, there is no research out there. So it is kind of, you're not going to hear Dr. Lou or I say, go, it's 100% great and it's going to work for you and be safe, because we don't have the research.
Yeah, nor will we say it's 100% a no.
Right.
Because I just don't know. But remember, sometimes your neuroendocrine is not the thing that's going to kill you. It is your obesity that's going to kill you. And so if that's the situation, then we have to choose what is the more of the priority.
Got it. Thank you. Folks, we got just about 10 minutes left. We're going to keep plugging along. By the way, there's about 100 comments saying fog. Eileen says, please explain SUV numbers on gallium dotatate as it relates to having PRRT treatments.
I'll explain, yeah. So SUV stands for, it's
how bright.
Well, it really stands for sports utility vehicle.
I know.
But it stands for standardized uptake value. And what it is basically, as Heather said, it's kind of like the brightness of the PET scan. So remember, the old PET scan that we used to use just looked at sugar. It's like how much sugar does the tumor eat? Dotatate PET CT is not like that. It's how much receptor is bound to it, right? It's like a lock and key system. So the more it's bound, the more landing places or whatever you want to call it, there is for it. So in general, if people have a very high SUV, it means they have a whole bunch of receptors. So there's a whole bunch of lock and key systems that are available to you. And since PRRT is a lock and key system with a little tiny nuclear bomb on it, that means you can get more of it in there. So it definitely does correlate with the efficacy, but that's not really what it is. If you really want to know what it is if you have very, very, very low uptake, the PRRT doesn't work very well. Okay, you're essentially not a candidate because there's no lock and key system to even bind to. Okay, but if it's very, very high, it does not necessarily mean it's going to be super, super awesome. It really has to do with what type of tumor is, how fast it's growing, what the grades are, and all those other things. So the efficacy of neuroendocrine of PRRT, which is the commercial name is Lutathera, the efficacy really has to do with the biology of the cancer. It's much, much more effective for small bowel. It's less effective for, it's good, but it's less effective for pancreas. It's less effective for rectal, and it's less effective for lung. So if you go down, so for small bowel, I think someone asked this question. If you do small bowel, you kind of hope you get 3 or 4 or 5 years out of it to kind of hold things quiet. Depends on how much disease, depends on when you use it, depends on how much surgery you have. It depends on all these things. But for like metastatic rectal, it may last for a year or maybe a year and a half or 2. These are all very, very generic.
Sure.
Please don't pin me on any of these things. Pancreas is probably about 2 or 3 years, depending on the situation. Lung is probably about a year and a half to 2, like in that general range. And it is not generally a shrinking therapy. It generally just keeps things quiet for that period of time. Some people have amazing responses. I'm not going to lie to you. I've seen some of those, but I worry because then it comes back with a rage. And so this is what becomes, the devil is in the details. And if you don't have someone who's done this 10,000 times, they won't know the details. And that's where it becomes a challenge for us.
Melissa says, if NET docs don't pay too much attention to chromogranin A marker and they don't overemphasize changes in SUV from one pet to another, what are critical diagnostics for marking progression?
Size and growth and symptoms. Rain.
Yes.
No one dies of an SUV.
Hmm.
No one dies of a chromogranin. They die of growing tumors that eat your liver and block your intestines and prevent you from breathing. That's what happens. Or they put out so much hormone that destroys your heart valve and kills you.
Got it. Is there a blood test similar to the NET test?
Well, for any of you who've met Dr. Maudlin, there's no one like Dr. Maudlin. So let's put it that way. The answer is yes, maybe. So let me back up a little bit. So the NET test is a test that was developed probably about 10 years ago by the Wren laboratories out in Connecticut. Really very smart, very brilliant people. And they wanted to look at what's called a multi-analyte, which is what they look at multiple things inside your blood instead of just like one thing, like chromogranin or serotonin or whatever. So they're continuing to work on it. I think it's very, very interesting. I'm not one to throw the baby out with the bathwater. I just haven't quite figured out how it works yet. But they found that it may work to help predict PRRT. It may help to figure efficacy of PRRT. It may give you a sense of these things. So I used to do it. In fact, I think there are a whole bunch of boxes in Heather's office that are still there. But I personally couldn't quite figure out how to make it work for me. And so until Dr. Kidd comes back to me and says, okay, Eric, this is how we use it, which I'm happy to do, I just don't use it very frequently. So I don't use chromogranin because it gets mucked up too much by other things. And I am I'm a seeing kind of a person, right? I measure twice and I cut once. Mm-hmm. So I get scans.
A lot of the people that have been asking questions have included their Ki-67 score. Susan says, how important is it to know your Ki-67 score?
Well, it gives you a good sense of what's going on, but they're all predictors. There's only one test, and all these people have heard me say it before. There's only one test that works 100% of the time. It is the test of time. That is the only one. Everything else we do is a surrogate for the test of time. Because I cannot tell you how fast your thing's going to grow, right? It's a little bit like telling me about, visiting Manhattan by visiting like one apartment in the whole city. Right? It's when you put it that way, I know it sounds ridiculous, but that's kind of how it is. but it can kind of give you a sense, right? If you go into Brooklyn, and that's not Manhattan, but if you go to New York and you go to Brooklyn, you might get one sense of it, right? But it may not reflect all of it.
Sure.
And so, but if you watch the city of New York over 10 or 15 or 20 years, you'll get a sense of what that city is really like. Okay, right? So that's the analogy. And I feel that way about people and this disease, because if you don't follow it over time, you won't know like what's going on. Maybe your Ki-67 comes back 20% in one tumor, but then all the other ones are 1%. I did this before. When I was younger, I had my poor pathologist, Dr. Shi, who was my dearest friend, and I tortured her. And I said, okay, I want you to cut every single tumor I remove out. And you people know, I like to remove like 30 or 40 tumors sometimes. And I said, you cut every single one, you stain every single one, and you tell me. And there are some people in which all of them are the same. And there's some people that were at 30% in one tumor and 1% in another. So this is why you have to think about it all the time and look at it all the time and follow it over time. Because the only test that works 100% of the time is the test of time. The Ki-67 is just a surrogate. It gives you a sense, but it's not perfect.
Thank you. Appreciate your question. Next one from Amy. Octreotide's not helping much at all with my husband's horrible diarrhea, except for the first 14 days post-injections. What else might you recommend?
Well, that's hard to answer because
Sure.
diarrhea comes in all kinds of different flavors. And I'm not saying I taste the diarrhea. I'm just
Stop.
saying that please.
I knew.
You knew it. You knew I was going to go there. Right? So
as soon as you said flavors.
That's right. So the problem with diarrhea is it literally, there are different kinds of it, right? So different causes. Is it from the surgery? Is it from the shot? Is it from exocrine pancreatic insufficiency? Is it from the hormones? So the good thing about the injections of lanreotide and octreotide is it masks it, right? It actually makes people feel better. But sometimes it doesn't always get down to the root of it. And so you got to figure out what is the root cause of it. So if it's truly from carcinoid syndrome diarrhea, right, which is from the hormone, then the correct therapy would be the shot as well as telotrestat, Zermelo, right? That would be the proper thing. Then, or debulking, or embolization, or whatever it is. If it's from bile, for example, then the proper thing would be a drug we give that's called Questran, cholestyramine. If it's from a gastrin, then you should control the gastrin with, whatever it is, your antacids. If it's from exocrine pancreatic insufficiency as a secondary effect of the shot, then you should give something like a digestive enzymes, right? I can go on and on and on. And this is, we have, Rain, I don't know if you know this, but I have a spell book. That's right. It's like a Horcrux with all the things on how to make people with neuroendocrine better. And it sits right here. And so we look at it all the time.
So you can cast spells on them?
Pretty much. I can live cast here and I can cast spells, exactly. But basically, so it depends. It depends. Yeah. So that's the problem. I can't answer the question because I don't have enough information.
Sure.
So what you need is a good doc who can figure it out and help you. I mean, maybe you shorten the interval between shots. Maybe you throw in some rescue shots.
Guys, team, we have maybe time for just a couple more. Amber says, hi, can you tell me what it means when I get the Gallium-68 injection? I get a reaction that increases my blood pressure, and I get pressure feeling on my thyroid. Is this like carcinoid crisis? How do I prevent this reaction?
Not really. So I saw this. So, okay. I developed this Gallium test, I don't know, like 10, 15, whatever. I don't know how long I've been working, but almost 15 years ago, we developed this Gallium test. And we saw this. People had... It is an immediate response to the IV injection of octreotide is what it is. And people have different feelings to it. Some people, their heart will race. Some people will get a little warm. Some people feel very tingly. It usually goes away within about an hour. So it's not that it's a carcinoid crisis because it is a stimulation. It's just the effect of octreotide, which is a powerful suppressant of whatever your body is. And it gives you these feelings. But the half-life of the drug is it's like 7 minutes. It goes away really, really fast. And the half-life of the gallium, which is a little bit different, is obviously longer, or copper, or whatever you're doing. But the drug is IV injected, right? It's not like a sub-Q shot or the big, the big shot that people get. So it goes bang right away, but it goes away right away. So if you can hang tight and just tolerate it, it's usually pretty well tolerated.
Final question. What are you both excited about in the next coming years? I know there's a lot of activity in the space right now.
Well, you're the new.
Or it could be what are you hoping to see progress in?
I think I would be very happy to see more providers in the space collaborating more and talking to one another and learning from each other. I think there's some, like Dr. Liu said, some great, drugs and promising, treatments coming in the pipeline. So I think it's an exciting time to be in the space.
Let me tell you how I feel about it too. I feel very blessed to have people like Heather. The reason that I didn't want to do this by myself is because people like Heather are the ones that take care of you, right? I mean, she's the one who really thinks about you, loves you, wants you to feel well. And we need more and more people like that. And so, I can't speak for any of the other groups, but for the Healing Net Foundation, we think that's so critical. And so spreading the word and developing programs, if you do breast cancer or colon cancer, there's like all these like things that are set up for it, but a lot of it isn't that well set up for neuroendocrine. And so we need to set up, fellowship programs so that people can learn about neuroendocrine so they can be true neuroendocrine specialists, like true neuroendocrine specialists. This problem is only going to get worse over the next 5, 10, 15, 20, 25 years. It is only going to get worse. And so we have to be prepared. And so one of the things that Heather and I and the Healing Net Foundation and our clinic are doing is we're really working very, very hard on wellness. So you can see here in the corner, it's a picture of Ken Artell and his wife and me. And I believe in this thing called CEASE, in which you work on your sleep, you work on your exercise, you work on your eating, and you work on your spirits. You work on that, and the rest is up to me and Heather. It's not up to you, right? You can't decide to go and order a Gallium scan. Although I hate to say this, most of you end up taking control of your own care, but that's not fair. That's not great. So I'm excited about the usual kinds of things that people, clinical trials, new therapies, new treatments. I mean, look, that is not interesting to me. They're important, but that's not interesting. What is interesting to me is how people learn about it. People get diagnosed quickly. People find the right doctors who can care for them. People who understand, hey, maybe I can live with this disease instead of dying of this disease, and understanding that it's not all about the disease. It is about your life. It is about your well-being. It is about the people that you love. I mean, I hate to say this, but there are other diseases that are worse. Suicide is a terrible, terrible disease. Gun violence is a terrible, terrible disease, and traffic accidents. Flights nowadays. I mean, those are all these things are happening, and so I tell people all the time: every day is a blessing. Every day is a gift from heaven, and every moment that you can share with the ones that you love is precious. And so we need more of those. And just let me order your scans and figure out your medicines and all those kinds of things. I mean, I tell people all the time, I work as hard as I do, and I work really hard. I mean, I think most people know that. I work as hard as I do so that you can do those things, so you can eat well, so you can be with your family, so you can enjoy the things. Every holiday that people get through, every birthday they experience is a gift.
Yeah.
Every grandbaby.
Every grandbaby. And so that's the reason Heather and I work so hard for you, and why things like the Healing Net Foundation try to put these things together so that we can help you. And if those things happen, those are the things that excite me, Ray. Those are the things that I want people to love.
I love that answer so much. I'm going to go hug both my kids right now. And I agree completely with you. And so do the people in the comments. Everybody say thanks, Heather. Appreciate you both so much for being here. This has been outstanding. And folks that are commenting personal messages, they're able to see the comments. So even though I haven't repeated them, they're seeing them. Don't you worry. Dr. Liu, Heather, thank you both so much for being here. I appreciate your time.
All right, pal. Thanks for doing this. Bye, Rain.
Bye.
Absolutely. Bye, everybody. See you next time on Luncheon with the Experts. Stay healthy. Stay safe, everyone. Bye-bye now.